And ivabradine also, you must have heard, I don't know how many of ivabradine, that's the latest drug we are using for last 10 years. Ivabradine uh, is the ion channel blocker. It acts specially in the ion channels of the uh, uh, SA node, pacemaker. SA node itself is a small tissue, this much small tissue, a peanut size tissue. There you have ion channels. We call them as funny channels. These funny channels, the ivabradine is a wonderful drug. It reduces the heart rate by depressing the ion channels. It does not have any effect on the heart, unlike beta blockers. Beta blockers have, though they also reduce the heart rate, they have effect on the heart. But these ivabradine, if patients are not able to maintain on beta blockers, you can include the ivabradine medication. It's a wonderful drug, ivabradine, very good drug. Then if all medicines are not helping, patient is going into chronicity and the symptoms are not getting under control with all these medication, then you have to think of so many other things. Heart failure is a big subject. It's a conference, 3-day conference subject. I have attended 2-3 heart failure conferences in different parts of the world. So implantable cardiac defibrillation, the defibrillator is implanted, and whenever the heart is going into arrhythmias, it will give a shock, or it will sense and it will give a shock automatically, and it gets into sinus rhythm. They get daily 10-15 shocks. They can feel also the jolt suddenly. That is implantable cardiac defibrillator. And cardiac resynchronous therapy, CRT, like a pacemaker. Sometimes patient have very bad arrhythmias like a bradycardia, complete heart block. You have to, we use pacemakers to keep the heart rate normal. Of course, if the patient has ischemic heart disease, you have to do a coronary angiogram and then plan for some revascularization strategies like putting a stent or balloon dilatation or sending the patient for bypass surgery like yesterday we were talking. And we also have a latest advanced ventricular assist device. There's a mechanical circulatory support device. This only we use very rare. It's very expensive. It is done by only very expertise electrophysiologists, super specialty in the cardiology. They do this. The ventricular assist device. They cost some lakhs of rupees. This is also can be kept for only few couple of years because anybody is waiting for transplantation. That's one step before, just to stopgap. The VAD, ventricular assist device, can be used in patients we are preparing for transplantation. Ultimately, the best treatment, of course, is the refractory heart failure. Of course, heart transplantation, which is not an easy thing. You should get a heart. You should have that much of money. You should be fit enough for surgery. So if the patient is very old, they will be having other problems like diabetes, kidney failure. So it's a big a subject by itself. There are transplant surgeons, heart transplant surgeons in the country. So this is all about heart failure. And today we will also talk for 10 more minutes or 10-15 minutes about cardiomyopathy. What is cardiomyopathy? So far we have completed heart failure. Now we are talking about cardiomyopathy. What is cardiomyopathy? The disorder of the myocardium. It's a muscle related, heart muscle related disease. Any disease which is occurring in the myocardium, we call it as cardiomyopathy. The classification again is based on the structural functional defect in the myocardium. Again, cardiomyopathies are classified into inherited, ischemic, infective, toxic, and if you don't know anything, you call it as idiopathic. So cardiomyopathy is a muscle-related myocardial disease. It can be structural cardiomyopathy or functional also. And the causes are inherited diseases, some genetic disorders, or ischemic heart disease, which is again a common ischemic dilated cardiomyopathy, or infective, metabolic, diabetic, toxic, and idiopathic. These are the types, the classification of cardiomyopathy. In cardiomyopathy, again, heart failure is the ultimate symptom that will be. Otherwise, you don't even know. Cardiomyopathy can produce arrhythmias, can produce heart failure, can produce chest pain also, palpitation. So anybody coming and the signs and symptoms of both heart failure and cardiomyopathy are overlapping with each other. So you should be able to. Right, dilated cardiomyopathy. I think I'll show you a couple of pictures here. Dilated cardiomyopathy, where the all chambers are dilated. All four chambers are dilated. Here, there is no thickening. This is not hypertrophy. And second variety is hypertrophic cardiomyopathy. Hypertrophy means the cardiac muscle gets thickened, and it can be concentric, involving entire LV, or it can be localized, septal or apical. So obstructive obstructive cardiomyopathy, hypertrophy obstructive HOCM, HOCM, hypertrophic obstructive cardiomyopathy. So these are different varieties of hypertrophic cardiomyopathy. We have dilated cardiomyopathy, where the myocardium, the left ventricle becomes very big and thin. Now, whereas hypertrophy, the cardiac muscle wall becomes thick or septum becomes thick, causing the impairment of the cardiac function and pushing them into heart failure. Ultimately, they will die of heart failure. What is the pathophysiology? Why should someone's myocardium becomes very thick? The pathophysiology is not very clear, but histopathologically, there is myofibrillatory loss. The muscle cells are lost. The surrounding tissue matrix also gets lost, and the fibrosis, the fibrous tissue gets deposited in the normal myocytes. That's called interstitial fibrosis. Just like your lung fibrosis, myocardium also gets fibrosis. So that is hypertrophic cardiomyopathy. In cardiomyopathy, we also have alcohol. Alcohol can also call cardiomyopathy. We call it as alcoholic cardiomyopathy or diabetic cardiomyopathy, dilated cardiomyopathy, hypertrophic cardiomyopathy, and there are genetic inherited cardiomyopathies where it can be autosomal dominant transmission. They have genetic problem in the cardiomyocyte. Therefore, this interstitial fibrosis takes place and heart becomes stiff and it cannot pump well. And they will again lead into low cardiac output and heart failure. So usually in dilated cardiomyopathy, in hypertrophic cardiomyopathy, there will be a defect in the ventricular relaxation. Whereas in dilated cardiomyopathy, the defect is in the ventricular contraction. So either systolic failure, either heart. This side it is diastolic failure. That when somebody has heart failure, and if you do a 2D echo, if ejection fraction is normal, you call it as diastolic heart failure. If ejection fraction is reduced, you call it as a systolic or heart failure with reduced ejection fraction. I'll draw here.